So let's get into chapter 12, part 2. The next kind of shock that we're going to talk about is hypovolemic shock. Hypovolemic shock means hypo is low and volemic refers to volume, so its shock is the result of a low volume. This means that you don't have enough of the fluid, the plasma, the volume in your pipes. So your heart can be working at 100% and your pipes can be clear as mud, clear as day, but your volume doesn't have the capacity to support the needs of the body. This can be due to both external bleeding, internal bleeding, non-hemorrhagic, non-blood loss related. It may be due to thermal burns that have placed a loss of plasma as the cause. Additionally, as I've said previously, dehydration is another way that we see a lot of people end up in shock. When you become dehydrated, you lose the volume in the tissues and in the pipes. But you can also get fluid loss as the result of vomiting for long periods of time. So when someone has the flu or they have a gastrointestinal disease, that's one of the reasons why we really push fluid intake, is so that they don't get dehydrated and go into shock. So those are all of the causes from the circulatory system. But as I said, we need to also have the oxygen in the system in order to circulate blood that is appropriately oxygenated. So when you have respiratory insufficiency, you will see shock in your patients. They are able to move the blood around, but because they cannot breathe appropriately, they're going to have problems oxygenating to the necessary levels. Anemia is one way that we see a respiratory insufficiency. So we are breathing in and out, but because we do not have the right levels of red blood cells necessary to carry the amount of oxygen that we need, hypoxia will occur. Certain poisonings will make our red blood cells believe that what they're carrying is oxygen when in fact they are not. Or cyanide poisoning. Carbon monoxide poisoning, it mimics oxygen, but it's obviously carbon monoxide on your blood cells. And then cyanide makes the red blood cells break apart, so you don't have the ability to carry the oxygen that you need to your tissues. So how does shock progress? Well, it's not like immediately obvious to most providers. It's not one of those where once shock starts, you go, oh my God, your patient's in shock. But you do need to recognize those early signs and symptoms just as much as you need to recognize the late ones. The important part is when you recognize early signs and symptoms, treating it then, and you shouldn't come across the late signs and symptoms. If you wait and hold treatment until you see some of those later signs, then you are putting your patient at a higher risk of death. So our first is compensated shock. That's the early stage. That's when the body initially recognizes that something is wrong and takes steps to improve it. So, oh, I don't have enough oxygen, let me breathe more. Ooh, I have oxygen but not enough blood, let me pump the heart faster. So they're trying to compensate for the blood loss or the lack of oxygen. The problem is after a certain point, if things aren't fixed, the body's going to get tired. And when that happens, it's going to enter decompensated shock. So decompensated shock is basically when the body has quit trying to make up for the things it's not getting. So it's no longer going to have the energy to maintain a high heart rate. It's no longer going to have the energy to maintain an increased respiratory rate. And then if still left untreated, then your patient's going to get into the stage where it's irreversible. So then you're going to get it to a point where shock is untreatable and it is likely that your patient is going to die. And so then there's compensated and decompensated shock. Table 12.3 will show you the signs and symptoms of both. We use blood pressure, obviously, as a vital sign. I tell you that it is one of the required in your practical skill stations. When you're getting a full set of vitals before giving a medication, blood pressure is one you want to have. But it is not what we are waiting to see change in order to diagnose shock. You've got to understand that if you are waiting for the blood pressure to drop significantly to see those narrowing pulse points, you're probably at a point where you're behind the 8 ball. It's kind of like jumping off a cliff and not realizing you've done it until you're halfway to the ground. Kind of too late, and you're going to have to do a lot more work to stop the damage. So we kind of expect shock in certain patients. So patients who have a spinal injury, we're going to expect neurogenic shock. Patients who have a major heart attack, obviously that's cardiogenic shock. Patients in anaphylaxis, we expect that because it's distributive shock. So we've got to get an understanding of those patients that we just need to prepare for. People with significant blood loss, people with significant injuries to the spinal column, to major and multiple bones. So, how do we recognize and treat shock? Well, first, and it doesn't change, when I talk about recognizing and treating, you will always start with scene size up. Understanding that anytime you see on a test question, what's the first thing you do? If scene size up and personal safety are an option, that's always the best option. Because in any call, regardless of the dispatch, you want to start with that appropriate scene size up, and you want to put on your appropriate personal protective equipment. Putting on your gloves and your eye protection for traumatic scenes, making sure you know what you're about to go into and that your safety is the top priority. Then, as you learned in patient assessment, once you've done that, you're going to move on to your primary assessment. So remember, on the skill sheet, your scene size up includes number of patients, the need for assistance, whether or not the patient has a spinal injury. And then you're going to move into your primary assessment. And you're going to do your airway, breathing, and circulation. You're going to look for level of consciousness. Are they awake and oriented? Are they altered? You're going to look for those life threats associated with airway, breathing, and circulation. If they're bleeding, you're going to stop the bleeding. If they've got an airway issue, you're going to suction or insert an oral airway, bag them, or place them on 15 liters non-rebreather. And you're going to determine whether they are a high or a low priority. Are they load and go? Are they stay and play? All of these are part of that assessment sheet. If your patient is in potential shock or has a mechanism of injury that increases the risk of shock, then let's put them on oxygen, 15 liters, non-rebreather. Get ALS if necessary, because if they've got low fluid, at least for the duration of the call, an IV fluid, IV saline will actually help. Okay, so again, part of the primary assessment. What's your general impression? Does their skin color and overall work of breathing upon walking up to them make you think that they're sicker than they're really presenting or than dispatch gave you? Airway, is it open? If yes, great. If not, open it. Head tilt, chin lift. Breathing, are they breathing? If yes, is it adequate to support life? If no, let's bag them. Let's put them on oxygen. Let's suction the airway. Don't forget on your airway, before I forget, the oral or nasal adjunct. And then circulation. Do they have pulses? Are they equal? Are they present? How is the pulse? Is the heart rate bounding or is it weak? Do you see any major bleeds on a head-to-toe assessment? What's the skin color, temperature, and capillary refill on your patient? Okay, rapid pulse. You have a pulse that's outside of the normal range of 80 to 100. You likely have a patient who is in compensated shock. This also means you may find cool, clammy skin, and you've got to treat the bleeding. Hypovolemic shock can be mitigated, can be not prevented, but can be treated by treating major bleeds. Good way to increase the volume is to stop by losing. And then again, our high priority versus low priority, all part of our primary assessment. Once you've done that, we move into the secondary assessment. In your load and go patients, your secondary assessment should be done in the back of the truck. Remember, load and go means 10 minutes on the scene. Secondary assessment allows us to do a more in-depth assessment of the patient, and we've talked about this. So if it's trauma, you're going head to toe to check for any injuries that were not considered life-threatening, and you treat them then. If it's stay and play, if it is a medical emergency, you're going to focus on the area that's impacted and make sure there's no traumatic injury. Or you're going to do a focused assessment on a trauma of the area that is hurt. You're going to take a baseline set of vitals: blood pressure, pulse, respirations, skin. If you have a pulse ox, you can do that as well. And then as you transport, we're doing the reassessment. We're reassessing the ABCs and the mental status. We're reassessing our vital signs and making sure that any interventions are maintained and working, and adjusting if necessary. So let's look at our emergency medical care for shock. And I can't stress this enough. Once you've found it, treat it. If it's hypovolemic shock, you're going to treat the bleeds. If it's shock because the respiratory system is failing, then you need to treat that. Airway, breathing, and circulation and treatment of those life threats are the best way to help this kind of shock. So we need to consider, is it neurogenic? And we've got a spinal injury, so we need to do inline stabilization. But we should be doing all of this during our A, B, and C check. Because remember, if you find a problem at A, B, and C, you treat a problem at A, B, and C. Another thing to consider is the ability to keep the patient calm. Maintain a good level of breathing. Calming them down can help them calm their respirations. We're not allowing them to eat or drink. You really shouldn't, any patient, except, we'll talk about when there's good. If it's the need for spinal immobilization, put them on a backboard, oxygen, and assessment of breathing throughout the entire call. This is oxygen, covering them to prevent heat loss, really some of the best ways we're going to treat shock. Consider ALS. We can't give them volume, but an ALS provider can. And because a patient in shock is unstable, we're going to consider this a load and go, and they are going to get vitals monitored every 5 minutes. So the patient that's in shock because of heart attack isn't generating the power to pump the blood. So we've got to consider whether we position them appropriately. Is sitting up going to help? Gravity, not having the gravity of the chest pressure when they're laying flat, allowing them to get more oxygen. The problem with patients who are in cardiogenic shock is they're going to have low blood pressure. So nitroglycerin, which is our normal treatment, might not be right or the best treatment. These patients in cardiogenic shock are going to have weak or irregular pulses, anxiety. They might talk about a fluttering in their chest, nausea, and low blood pressure. Oxygen, oxygen, oxygen. I cannot stress that enough with these patients. So cardiogenic shock patients, position of comfort, checking their ventilations. If they're not adequate to support life, consider bagging them and keep them calm. Notify the hospital as well of your suspicions of the heart attack. If it's cardiac tamponade, oxygen. We can't do anything. We are not allowed to do a pericardiocentesis where we put a needle into the heart wall or into the heart sac and pull out that extra fluid. So it needs to be a load and go patient, oxygen and transport. A BLS provider can do nothing for attention pneumothorax. So again, oxygen, transport, call for the ALS provider. But in reality, if they can't come, getting them to the hospital is the best treatment. Septic shock. How do we treat septic shock? It's going to sound like I'm saying this again and again, but I am. Oxygen and transport. Again, covering them to preserve body heat so that they're not losing too much, and getting them to that definitive care, getting them to the treatment team who can give them medications and treat them appropriately. Oxygen and transport. Really the easiest things we can do for a shock patient. Neurogenic shock, because this is likely a spinal cord injury, we need to make sure that we put them on a backboard to transport. This is going to require hospitalization, and if it's a new spinal cord injury, it's going to require a lot more than we can provide them. Our goal is not to further aggravate the problem. So how do we treat it? Oxygen and transport. But this one, now we're in a new one. Anaphylactic shock. We do have the potential to apply a medication to this patient. We'll talk about the medication in a different chapter, but know that anaphylactic shock is oxygen, epinephrine when prescribed, and transport. Recognizing that once you've given the drug once, there is a chance your patient will continue to get worse. So having an ALS provider to give epi out of the drug box is important too. So psychogenic shock, remember, is really fainting when it's not complicated by other issues. Normally, once they've fainted, as long as they didn't cause a traumatic injury, they're going to become conscious again. We need to check for injuries if we get there and they're conscious, making sure they didn't hit their head or cause other physical damage during the fainting spell. And we need to consider the underlying causes beyond being surprised. So as we talked about, this could be a heart murmur or a brain aneurysm. So I'm going to really try to talk them into getting checked out. And if I do transport them, oxygen. That's really the only thing we can do for these patients, and treating any injuries that occurred as a result of the fall. Now, hypovolemic shock. If hypovolemic shock is caused by external bleeding, then we want to treat the external bleeding. We need to recognize if it's internal bleeding that's causing the hypovolemic shock. And we'll talk about those signs and symptoms in a different chapter. We need to provide support to the airway and oxygen and transport. So again, if we see bleeding in these patients, we treat it, but otherwise they get treated like all of the other shock patients. Oxygen and transport. When the shock is caused as a result of respiratory insufficiency, our focus is going to be treating the airway and the breathing, supporting the ventilations, whether it's through a bag valve mask or just through supplemental oxygen, clearing the mouth and throat of any obstructions. So if this is the result of a foreign body airway obstruction, or they've got bleeding or other bodily fluids in their mouth, we're going to suction it out. But once we have gotten the airway clear, we're going to give them oxygen and transport. So let's finish up with talking about older patients and shock. older patients who are in shock are going to have different signs and symptoms than younger patients, partly because they may be on medications that are going to either mask or mimic the signs of shock. For instance, a patient who is on beta blockers may normally have a low heart rate, and I'm talking like in the 40s. So if you take a heart rate and get a heart rate of 80 in a patient on beta blocker, that may be awful. That may be a sign of compensated shock. That's why it's important to both talk to your patient and use both vital signs and the symptoms of your patient, your general impression, to determine how you're going to treat your patient.